I have the pleasure of representing our group. Our investigators from multiple countries embarked on the study of Tisagenlecleucel in large cell lymphoma, and this is a longer-term follow-up of the preliminary early data that was presented last year at ASH. Just to state that this is, again, you saw some of these, the early part, Tisagenlecleucel is the first approved gene therapy, the first approved CAR therapy in the United States. May 1st of 2018, it was approved for large cell lymphoma. It is a single-arm, open-label trial, so there's no randomization. We know where patients are getting, and we will update this analysis as this is 19-month median for follow-up. The reason this is important is that early on, when you look at data early, you can always worry that the trial has selection bias. You pick the best patient as it doesn't represent real life. As you move into 19 months, follow-up, the median 19 months, you are now looking at the real natural history of disease. And these are patients with multiply relapsed refractory large cell lymphoma. The primary endpoint was best overall response, which is CR and PR, complete remission and partial remission, with key secondary endpoints of duration of response, overall survival, and safety. Now, just for the event, this will be presented tonight in poster session. I'll be there for most of it, or Dr. Stephen Schuster, who's our first author in the publication. This is just to announce that at 9 o'clock this morning, this paper has just been published by it was announced for publication by the New England Journal of Medicine. As far as the data, the overall response is 54%. Of which 40% were complete remissions, 14% were partials. Of the patients who had partial remission, we do know that half of them went on to develop complete remission over time. So the drug continues to work. Again, over time, you can convert from partial to complete. The overall response data was seen. There's multiple subgroups of large cell lymphoma. It's a very complex disease, but whether all the potential prognostic subgroups, we could not see a predicted group that was likely to be favored or also predicted to fail with CAR T. Also important is the median duration of response was not reached for the patients who were responders, and for patients who were in complete remission, over half of them, the median remained free and alive, with the median overall survival not being reached. And for all patients infused, it was 11.1 months. The figure on the right actually compares as an overlay of the data from the JULIET study compared to one prospective as well as one retrospective study of similar patient population. And again, early on, you have patients that will fail, but what we see is we're approaching, again, a plateau, but we're definitely seeing a change in the natural history of the disease to the best of our ability to interpret the data. As far as safety, we have similar profile, but not to the same degree as Tisagenlecleucel when treated with acute lymphoblastic leukemia. It's a lower degree of the cytokine release syndrome and neurotoxicity. And this may be in effect relate to the fact that when you infuse the cells, they don't immediately encounter in the same vascular space their target antigen. They have to traffic out of the vascular space into actually lymph node or spleen or other organs. And so this may, as hypothesized, may at least contribute to lower degrees of the adverse events seen, but we still do see 25% with advanced grade 3-4 GVHD. And again, I would also share that these grading system is a very liberal system that is that over-identifies toxicity compared to the Lee criteria, which has now become more generally utilized. Since the previous report, no new deaths of a cause due to any cause other than one patient with disease progression. No treatment-related mortality was seen throughout the entire study. And there were 3 early deaths, all related to lymphoma that progressed through. So in conclusions to share with you, this is the data with a longer median follow-up of 19 months. Just to say again the high points, the overall response was 54%, and for patients responding, the median duration response was not reached. In a similar population of patients, we would have predicted a less than 10% complete remission and a 5-month median survival. So thus, it was improved over historical options, and I would say the adverse events were similar. And this is just a final slide to say that when you begin work, I mean, this is the beginning, not the end. what we are doing is hoping you'll hear about ways that we can build on primary first-generation T-cell therapies. We have 6 current projects that are coming out of this database. Some looking at dosing rationale. We are doing 2 presentations on Monday. We'll be looking at regrading toxicity using the Lee scale or the neurotox scales that have become more commonly used. We're also doing work on health economics, as well as examining what happens when the cells are given in remission. So I want to thank you for the time and appreciate the effort, and I also will vouch for Dr. Oliver. This is the importance of this has become a health economic issue that we all need to be aware of and highlight. Thank you.